The materials. Oh, hello. Hello, everyone. Welcome to our PMHNP Would You Pass Lock It In Live. My name is Ledi Lutz. I am a board certified psychiatric mental health nurse practitioner. And today, I think a lot of you joined our live yesterday and kind of enjoyed the review sessions. So today it's going to be me and Dr. Morante will be joining us a little bit later. So I'm going to wait for some people to join us. So we want this session to be very interactive, okay? So we're gonna do 10 questions just like yesterday, and we're gonna break down. And I'm also gonna teach you some test-taking strategies and then tips, important things to remember so you pass your board exam in one take. All right, please say hi if you're on live with us today and put it on your chat box. All right, I think let's go ahead and start. But before I proceed, I just want to plug in, like we came up with review materials. So if you go to our Etsy studio, we're gonna post the link on the chat box where you can purchase that. So let's go ahead and start with our first question. Question number one. So a client taking haloperidol has fever, severe muscle rigidity, altered mental status, diaphoresis, and elevated CK. What is the priority diagnosis? A, it's serotonin syndrome. B, neuroleptic malignant syndrome, also known as NMS. C, acute dystonia. Or D, malignant hyperthermia. I'm going to give you time to put your answers on the comment box. Okay. All right. So what is the answer? The answer would be letter B, NMS. Why? Why do you think that will be the answer? Note, go back to the question. What are your keywords? The patient is taking haloperidol. And what is haloperidol? It is an antipsychotic, okay? And has high fever, lead pipe rigidity, elevated CK, altered mental status. So these are classic NMS findings. So why are the others wrong? Let's break it down. Letter A, serotonin syndrome. By the name itself, it's serotonin syndrome. So it's usually just caused by SSRIs, MAUIs, SNRIs. So usually the findings for serotonin syndrome is clonus, hyperreflexia, and diarrhea, not lead pipe rigidity. If you see the word rigidity, think NMS right away. Next option was acute dystonia. So for acute dystonia, it's usually just muscle spasms only, no fever, and no elevated CK. And then finally, malignant hyperthermia. Usually this is triggered by anesthesia. So it is not by an antipsychotic medications. So next slide, please. So we have a visual that can help you remember. If you see rigidity, the word rigidity, think about NMS right away, okay? When you see clonus, you think about serotonin syndrome. This is a board exam pearl. So you will be tested if you're able to identify your serotonin syndrome and NMS because these are emergency situations. So for test-taking strategy, when you see antipsychotic, fever, rigidity, and high CK, always think of NMS. Don't think other things. It's NMS right away. Okay. For mnemonic pearls, so NMS for fever, serotonin for shivers. For fever, F stands for fever, encephalopathy, vital instability, enzymes are elevated, and then rigidity. And for serotonin, it's shivering, hyperreflexia, increased temperature, vital instability, encephalopathy or agitation, restlessness, and sweating. But then again, the biggest differentiator between the two is that NMS is caused by antipsychotics and serotonin syndrome is caused by your SSRIs, your antidepressants. Okay? Any questions with that? And question, this might come out of the board. What is your treatment for NMS? Anybody on the chat? Your treatment is your bromocriptine, okay? Remember that. Your treatment for NMS is bromocriptine. Okay. Any questions? All right. So let's proceed. Question number 2. A client taking lithium reports vomiting, diarrhea, coarse hand tremors, confusion, and ataxia. What should be the PMHNP do first? So put on your nurse practitioner hat. You are not a registered nurse. You are a psych NP. So think like one, okay? When you're answering these questions. Letter A, increase fluids and continue lithium. B, hold lithium and obtain a lithium level. C, add propanolol for tremor. And D, decrease caffeine intake. I'll give you time to answer. Hi, Jan. Thank you for joining us today. Okay, remember the patient is taking lithium. Lithium has a narrow therapeutic index. That's why we have to monitor their lithium levels. Okay. So what is the answer? Our answer is, you're right, Jan. It's letter B. You hold the lithium and obtain a lithium level. Okay, what are your signs of lithium toxicity? Vomiting, diarrhea, coarse tremor, ataxia, and confusion. So your priority action as a provider is you have to hold the medication, check the lithium level, and assess for your kidney functions. Okay, so why do you think the other options are wrong? So A, increase fluids and continue lithium. Yes, you have to increase fluids for patients who are taking lithium. That's why you have to educate them. But do you have to continue the lithium when you see that you're seeing all of these symptoms already? No, that's dangerous because you're already suspecting what? You're suspecting toxicity. All right, so when it's toxic, it's not good. So you have to stop it right away and make sure to check the lithium levels. Remember, the board exam will test you if you are a safe provider. So these things are important to remember. And then, do you have to add propanolol? Propanolol is used for patients who are having like benign fine tremor. It doesn't address toxicity. Remember, fine tremor is a side effect and it happens all the time. Coarse tremor, that means it's toxic. So remember, fine, side, both have eyes. When it's coarse, it has an O, that means it is toxic. So remember those, okay? That's your memory trick. Do you have to decrease the caffeine? It may help with minor tremor, but not for toxicity. In this case, the patient already has like mental status changes. It has coarse hand tremors. It has a lot of GI symptoms. So you have to hold the lithium and obtain a lithium level. So first step, okay, remember toxicity. Hold the lithium and obtain a lithium level. I'm never gonna stop repeating this because this is very important. Why? Because you could harm your patient just with one wrong education, okay? So when you are starting the patient on lithium, you also have, it is your responsibility to educate your patients. What are the symptoms to watch out for, okay? So for board style cues, remember your GI symptoms, coarse tremor, confusion, ataxia. So you have to suspect toxicity right away, okay? For mnemonic pearls, to remember what are the toxic symptoms. Tremor, T is for tremor, O is for off balance, that's ataxia. And then X, extreme GI upset like vomiting, diarrhea. I for impaired thinking, which is altered mental status or confusion. And then C, you check the lithium level and seize the lithium. So what not to do first in cases like this when we're talking about toxicity? Do not give the next dose. You have to tell the patient, you see the symptoms, you have to stop taking the lithium right away. Do not just reassure the patient. If you see coarse hand tremors, you'll be like, oh, it's okay, it's a side effect. Be very careful, okay? Be very careful. Remember, if it's fine, it is just a side effect. If it is coarse, it is toxic, okay? Do not wait for the symptoms to worsen. Lithium has a very narrow therapeutic index. That's why we keep repeating, the safety cues for when we are prescribing lithium. And then do not treat lit. This is like a mild expected fine tremor, okay? On boards, safety comes first. Stop lithium before further evaluation. Um, okay. Any questions? I think everyone got the right answer. All right, let's proceed to the next question. Question number 3. A client with treatment-resistant schizophrenia starts clozapine. Which monitoring parameter is most essential? Remember yesterday we talked about olanzapine? So again, a client with treatment-resistant schizophrenia starts clozapine. Which monitoring parameter is most essential? A, platelet count. B, liver enzymes only. C, absolute neutrophil count. Or D, serum sodium. I'll give you time to answer. Okay, we got some answers on the chat. Remember what we talked about yesterday? When it's 8, it's too late. So we should be monitoring the letter C, A and C, or also the absolute neutrophil count. Do you remember what's the normal value for A and C? Anybody? Yes, we are thinking that the patient can have agranulocytosis. It can be life-threatening. So you have to monitor your ANC. Anybody? Normal levels for your ANC? I'm going to wait until someone answers on the comment box. So for clozapine, can cause severe neutropenia or agranulocytosis. So ANC monitoring is required. So for clozapine, you have to watch out for ANC, myocarditis, seizures, metabolic syndrome, and constipation. But for this case, clozapine is no, 800 is wrong. The right answer, the normal value for ANC, it should be 1,500 and above. Remember yesterday, 800. If it's 800, when it's 8, it's too late. So you don't have to wait until your patient's ANC drops into 800. So it has to be 1,500. If it's like 1,000, you have to monitor closely and you have to request for ANC levels. So let's break it down. Why the others are wrong. For 8, platelet count, not really the primary concern. When you're requesting for platelet count, you're assessing for possibility of bleeding. Okay, liver enzymes only. Liver enzymes are very important. However, that's not the required monitoring. For clozapine, it is recommended to monitor the ANC. Okay, clozapine, ANC, think agranulocytosis. Serum sodium, not really the major safety issue for this one. Okay. So for test taking memory trick, remember, clozapine, you have to count the neutrophils. Clozapine, count neutrophils. So that will be your memory trick for this one. For test taking strategy, whenever you see clozapine, think ANC, myocarditis, seizure, metabolic syndrome, and constipation. But when you see on the choices ANC or absolute neutrophil count, you have to answer ANC right away. Okay. And then board style cues. So clozapine can cause neutropenia. or granulocytosis. So ANC is the must know to monitor. Always remember, you see clozapine, or granulocytosis, monitor ANC. So for clozapine is used for treatment-resistant schizophrenia. So if the board exam asks you what is the treatment for what is the what it calls like best treatment or primary treatment for treatment-resistant schizophrenia, it is going to be what? Clozapine, okay? Unique high-yield risk, severe neutropenia and agranulocytosis, and watch for fever. So these are signs and symptoms of agranulocytosis. Watch for fever, sore throat, or signs of symptoms. So think clozapine, blood count monitoring, all right? What not to miss? Weight, glucose, lipids, and metabolic monitoring are important, but if it's asking for the most important parameter to monitor when patient is taking clozapine, it's going to be ANC. Do not ignore infection symptoms in a client taking clozapine. So when you start prescribing clozapine, you have to educate your patient, okay? You have to tell them, like, when patients are taking medications, everyone responds. Remember your first pass from your pharmacology? So everyone absorbs medications differently. So you have to educate them of the medications that they have, I mean, the side effects that they have to monitor. Okay. So priority pearl, ANC outranks other routine monitoring when the item is testing clozapine safety. Remember, again, I'm going to repeat it so that you remember clozapine, agranulocytosis, ANC. All right. Any questions? Good job, everyone. Good job. You're ready for the boards. Okay. Question number 4. Before we proceed, make sure you follow us on social media, on Instagram, LinkedIn, on Facebook to be updated. We post a lot of questions every day. And we also came out with new review materials. So we're going to put it on the comments on the chat box where you can find those review materials. If you are a new grad, Past Review came out with the Master Fill book to help you when you're starting for your practice. You don't want to read thousands of like books, right? We did a lot of reading already. So you want to break down what is important, what to monitor. All right. So here's the PMHNP Mastery Psychopharmacology. It includes all pearls that could help you, practice pearls that could help you in your practice, especially for new grads. And if you are experienced, this would be really great too. Yes, Janet. Yes. If you're a new grad, I would really suggest to purchase this book. It really helps. Okay. So for the choices for question number 4, a client recently started lamotrigine, reports a new widespread rash. What is the best response? A, reassure patient. B, increase dose more slowly. C, add diphenhydramine and continue. D, stop lamotrigine and evaluate urgently. All right, we got some right answers. Good job. Yes, so we are thinking it's the Stevens-Johnson syndrome. So the answer is letter D. Stop lamotrigine and evaluate urgently. Okay, this is an emergency. So when you start patients with lamotrigine, you have to inform them of this signs and symptoms that they have to watch out for. So lamotrigine can cause serious rash, including Stevens-Johnson syndrome. What other condition that lamotrigine can cause? There's another condition that lamotrigine can cause. It begins with letter T, and it's also an emergency. It's toxic epidermal necrolysis. All right. So board exam Pearl, do you start lamotrigine on high doses? No, you have to titrate it slowly. So the risk increases with rapid titration and valproate. Good job, everyone. So let's break down all the choices. Why the others are wrong. Letter A, reassure? No, it's very dangerous, especially when you see a widespread rash. Stephen Johnson syndrome, it is an emergency. So the patient has to go to the hospital to be treated. Letter B, increase more slowly. Yes, that is, a practice that we have to do, but the rash has already been present. So you have to stop the treatment. Add diphenhydramine. No, it just masked the symptom because of the rashes. So doesn't eliminate the Steven Johnson tricks. So memory tricks, okay? Lamictal. Look at the skin. All right? Look at your skin. Lamictal. So board exams are simple. For cases like this, when you see lamotrigine, you see rash, you have to stop the medication right away. Okay? So for our mnemonics, rash, so you have to stop. Stop. S, stop lamotrigine immediately. T, triage and assess. O, outrule serious rash. Consider Stevens-Johnson syndrome or the toxic epidermal necrolysis. And then P, protect the patient. So you have to refer the patient. You monitor and provide supportive care. Have you seen pictures of TEN, toxic epidermal necrolysis, and Steven Johnson? It doesn't look good. Board exam pearls. Lamotrigine, okay? Remember, there are two major conditions that this medication can cause. It can cause Stevens-Johnson syndrome and toxic epidermal necrolysis. So the highest risk, it usually comes out like the first 2 to 8 weeks, especially with rapid titration. So what you have to do, you have to slowly titrate this kind of medication. You see any rush, it is a red flag, okay? You have to document, discontinue, and educate the patient. Again, I'm never gonna stop reminding everyone, when you're starting a new medication, it is our responsibility to educate these patients about what major signs and symptoms that they have to look out for and when to stop the medication, when to call you, okay? Consider dermatology consult if rash is moderate to severe. So again, when patient's taking lamotrigine and you see rashes, you have to stop the lamotrigine, assess the severity, and then you refer as needed. Never ever start lamotrigine restart lamotrigine unless benefits clearly outweigh risk and under special guidelines. So you might also be asked at the board, if the board asked a, a patient of Asian descent is taking Lamictal, what will be your initial, what should be included in your initial assessment? What do you have to do first? If you see a patient that has an Asian descent, Thai, Asian, before prescribing Lamictal or lamotrigine, what do you have to do first? Anybody in the comments chat. It may or may not have come out of the board exam. Anybody? If a patient is off, yes, you have to do genetic testing. Why? What are we looking for? What specific allele are we looking for? Yes, Janet, yes. RM Barba, genetic testing. But what specific allele are we looking for? Yes, specifically HLAB1502. Why? Because patients, especially of Asian descent with this allele, are higher risk of having Stevens-Johnson syndrome. Okay, another question. What other medication can also cause Stevens-Johnson syndrome? What other medication can cause Stevens-Johnson syndrome? Begins with letter C. Anybody? It's carbamazepine or tegatrol. Your phenytoin can also cause Stevens-Johnson syndrome, okay? But usually, um, Lamictal and lamotrigine, yes, that's correct, Crystal. Tegatrol. No, it's your anticonvulsants can cause your Stevens-Johnson syndrome. All right? Good job. Okay, any questions for now? I think everyone is doing a great job. All right. Question number 5. Yeah. A depressed client reports past episodes of decreased need for sleep, impulsive spending, pressured speech, and increased goal-directed activity. Pay attention to your keywords, okay? What diagnosis must be considered before antidepressant therapy? Again, a depressed client reports past episodes of decreased need for sleep, impulsive spending, pressured speech, and increased goal directed activity. What diagnosis must be considered before antidepressant therapy? Okay, I'm going to give you time to answer. A, it's bipolar. B, persistent depressive disorder. C, adjustment disorder. Or D, generalized anxiety disorder. Pay attention. Increased goal-directed activity. Decreased need for sleep. These are classic signs of a specific condition. Yes, Dr. Morante, keywords are very important. All right, the answer is of course, letter A. This is a board example. This condition is highly tested in the board exam, okay? So if you look at the question, right? Decreased need for sleep, pressured speech, spending sprees, increased activity. These are called hypomanic or manic symptoms. All right? So why do you think are the others wrong? Exactly, Latonia. If you start an antidepressant on a patient with bipolar disorder, that will cause more mania. Good job. Good job, everyone. I think we dropped this question earlier and everyone got the right answer, okay? So let's break down the choices, okay? Why are the others wrong? A, persistent depressive disorder? No, no. This condition doesn't have hypomania or mania. Adjustment disorder, it requires identifiable stressor. Okay, so it's only going to be adjustment disorder, requires identifiable stressor. And then generalized anxiety disorder, it doesn't explain manic symptoms. So if you look at the question, it says increased goal-directed activity, pressured speech. Your patient will tell you like, oh, I bought like 3 cars in one day. Okay. However, you have to remember there are 2 types of bipolar disorders, right? And it is highly, highly tested in the board exam. All right. So how do you assess? How do you assess for like depression and then bipolar? I mean, for bipolar, remember the mnemonic dig fast? DIGFAST. Remember those? So D for destructibility, I for indiscretion, G for grandiosity, F for flight of ideas, A activity increase, S for sleep decrease, and T for talkative. So remember, to assess for bipolar, you have to remember dig fast. DIGFAST again, destructibility, indiscretion, grandiosity, flight of ideas, activity increase, sleep decrease, and very talkative, okay? So let's review your bipolar disorders first, okay, before we discuss our image. So there are 2 types of bipolar, okay? Bipolar 1 and 2, all right? How do you differentiate them? You have to look into the severity and duration of the elevate mood episode. So for bipolar 1, It requires mania, at least one full manic episode lasting for 7 days or more. And it requires immediate hospitalization. So, mania can be high enough, it can be severe enough to cause detachment from reality. So, sometimes you may mistake it into like a psychosis, okay? So, for bipolar 1, major depressive episodes frequently occur, but are not required for a diagnosis. So remember, 7 days or more of manic episodes. So bipolar 2, it requires a hypomania. So at least one hypomanic episode. That means it is only lasting at least 4 days and at least a major episode in a lifetime. So hypomania elevates mood and energy, but is milder, does not cause psychosis, and rarely requires hospitalization. Okay. Depressive episodes are usually more frequent, longer, and deeply debilitating compared to bipolar 1. Okay. Remember, bipolar 1, one full manic episode, depression is not required for diagnosis. Bipolar 2 requires at least one hypomanic episode, but it also requires a depressive episodes. All right. So let's have some memory tricks. Mnemonic is manic. Think manic for bipolar mania. Minimizes need for sleep, acting impulsively, so spending money, or you would say like sometimes the patient would say like, oh, I'm sleeping around, I'm maxing out my credit card. So that is acting impulsively. Nonsensical or pressured speech, just like keep on talking and they're like nonstop, right? Increased goal directed activity, they're gonna start a project and they're never gonna stop until they finish it, and then they would lose sleep for days. So you have to assess like how long have you been sleeping, okay? Can do attitudes like overconfidence, like, oh, I can do this. I've never done bungee jumping, but I'll do it. All right. So for your board pearls, history of episodic mood elevation. So mania or hypomania, okay? Depression and is bipolar disorder. So for mania, remember hypomania, how many days? At least 4 days. For mania, it's 7 days. Okay. So if the patient is having like sad moods, you always have to ask them, like, hey, how long has this been going on? Were there days that you feel like your mood is elevated? You're very happy, that you're never going to get sad. So think of your manic episode. So, what is your gold standard treatment for bipolar? It's heavily tested in the board exam. This medication was mentioned earlier. Gold standard treatment for bipolar disorder. Yes, Crystal, you're right. It's lithium. Again, remember, lithium is the gold standard treatment for bipolar disorder. It has a narrow therapeutic index. Okay. Any questions? Okay, so let's proceed. Number 6. A 9-year-old has poor concentration, restlessness, irritability, and declining grades. After witnessing a domestic violence, what is the best initial approach? A. Diagnose ADHD and start stimulant right away. B. Start antipsychotic medication. C. Assess for trauma related symptom. Or D. Diagnose ODD. I'm going to give you time to answer. Remember, a 9-year-old has poor concentration. So look at the age. Poor concentration, restlessness, irritability, and declining grades after witnessing domestic violence. That's your keyword. After witnessing domestic violence. What is it? Witnessing a traumatic event is a stressor. So what would you consider? Good job. Letter C, assess for trauma-related symptom. So trauma can mimic ADHD with hyperarousal, poor concentration, irritability, sleep problems, and behavioral dysregulation. So sudden onset after trauma, assess trauma first, okay? So why are the others wrong? Diagnose ADHD. No, it's too early. It's too early. Start antipsychotic. There's no indication right now. Okay. ODD, oppositional defiance disorder, you don't have enough evidence. Okay. Memory trick. If there is a sudden situation, you have to think about stressors. Okay. All right. So test taking strategy. If symptoms appear after the words abuse, violence, loss, disaster, or a sudden change of an environment, think about trauma first. Okay. Best initial approach for trauma, you have to assess for trauma related symptoms. So for like I said, when the board exam gives you a trauma related cues or keywords such as violence, accident, or typhoon, your force majeurs. So especially for children, like irritability, restlessness, failing grades, these are signs and symptoms that can be triggered by a stressor. So therefore, you have to assess for trauma. So your mnemonic pearl for trauma: T for triggering event, R for restlessness or reactivity, A, attention problems can appear, U, upset or irritability, M, marked school decline. A is assess trauma symptom first. Okay. Okay, do not jump immediately, especially if there's like it gives you an age. You do not, and it's like, remember your Eric Erickson's. Do not jump into ADHD diagnosis. Stimulants, do not give stimulants right away. So you have to make sure that you assess first. So remember, why do we have to assess more for cases like this? Because sometimes, for children, depression can be manifested by trauma-like behaviors, such as this. If there is no trigger or stressor in the questions, you will consider depression. Okay? But when a question clearly defines a triggering event, a stressor, you assess for trauma. And how do you do this? Remember your old cards? When you are assessing, for chief complaints, remember your old cards? O as in onset, L for location, D for duration, C for character, A for aggravating or elevating factors, R for radiation, T for timing, and then S for severity. Okay? Why do we even ask this? Another thing, it may not be related to this question. Why do we have to ask really questions during intakes for their chief complaint? Because sometimes there are physical symptoms that are manifested physically. Why do you have to ask, like, aggravating? How did it start exactly? When did the symptom started? What triggered it? Okay, so say for example, for geriatric patients, if the board exam asks you, an elderly patient suddenly became confused and agitated, what is the very important question to ask is, when did it start? What triggered it? Because when you ask and they answer, oh, it just happened like yesterday, so you would think, oh, it's acute onset. So for geriatric patient, what physical condition would you suspect? What condition? If the patient, if elderly patient started having confusion and the onset is acute, what would you think? Anybody? You will think UTI or urinary tract infection. Good job, Crystal. Good job. So are you going to order antibiotics? No. Remember when I told you yesterday, you have to put on your nurse practitioner hat. You are not a primary caregiver. So if this question is asked in the board exam, what will be your answer? You refer them to their primary care provider. Okay, so remember that. That might be tested on the board exam. But also in practice, safety is very important. So you have to recognize the symptoms. Assessment, remember, ADPI, assess, diagnose, plan, intervene, and then you have to evaluate. Yes, I agree. Delirium is acute, okay? Dementia is chronic. So you have to ask these questions. Remember, again, your old cards. It has to be a practice that you have to do. When did it start? Where do you feel it? Okay? And how long has it been going on? Yes, they have to order labs, specifically urinalysis. But then again, if this is something that you have noticed, there are certain parameters that we can do as psych NPs. Are we going to order antibiotics? You can order labs, but are we going to order antibiotics? No, because that is a scope of practice under primary care physicians. Unless you are dual certified, then you can do that. Okay? All right. Good job, everyone. Good job. Question number 7. Which tool is most appropriate for assessing alcohol withdrawal severity? This is going to test you of your knowledge of your diagnostic tools. A, PHQ-9, B, GOD-7, C, CWA-R, D, or Vanderbilt. Again, which tool is most appropriate for assessing alcohol withdrawal severity? A, PHQ-9, B, GAD-7, C, CWA-R, and D, Vanderbilt. I'm expecting everyone to get this to get this right. Yes, it's letter C, CWA-R. Okay, PHQ-9 is screening tool for depression. GAD-7 is anxiety, by the name itself, is generalized anxiety disorder. Vanderbilt is used for ADHD. So you have to know these things. Another screening tool that is heavily tested in the board exam is COWS. You have to master when do you start monitoring, when do you start diagnosing, when do you start treatment, especially for your cows, okay? So for the CWR, it assesses alcohol withdrawal severity. PHQ-9 audit is used for alcohol use. DAST is for drug use, and COWS is for your opioid withdrawal. Remember, on your cows, what score can you start treatment? Anybody? I'll leave that to you as your assignment, okay? Cows, when do you start treatment? What score do you have to start treatment? Okay, so mnemonics, SIWA, check it with alcohol. SIWA, check it with alcohol. C, clinical signs, history of use, evaluate withdrawal, CWR scale, keep monitoring, intervene as needed, treat and taper safely. So board Pearl, CWR is the gold standard for assessing withdrawal severity. Assesses 10 symptoms, nausea, tremor, sweating, anxiety, agitation. Okay, scores guide treatment mild is 0 to 8, so it is a range. You start treatment, there is a range, there's just no specific number. And here's your answer: moderate 9 to 15, severe is over 16. Use the scores to guide benzo and dosing monitor response. Okay, always assess for vital signs, hydration, electrolytes, and risk for complications, seizures, and delirium tremens. Okay. Again, quick guide tool for your diagnostic tool. The answer is on the board. You start treatment on moderate. It's 9 to 15. PHQ-9 is for depression, GAD-7 for anxiety, Vanderbilt for ADHD, Connor also is for ADHD, ODID for alcohol use, DAS for drug use, and COWS for opioid withdrawal severity. Okay, any questions? Okay. A client says, I am going to shoot my supervisor tomorrow and gives the supervisor's name and workplace. What is the priority action? I really hope nobody gets this wrong. This is very important, okay? A, maintain confidentiality. B, take steps to protect the identifiable victim. C, explore childhood trauma. D, schedule follow up in 1 week. I'll give you time to answer. Yes, okay. It's letter, okay, Jan, Crystal, RM, Latonia, Shasta, Janet, good job. It's letter B. Take steps to protect the identifiable victim. And this is what law? Anybody put it on the comment box. What law that states you have to warn the patient? Anybody? What law requires you? Yes. Good job, Jan. It's your Tarasov. It is your duty to warn. Why C is correct? Because it has a specific victim, it has a specific plan, and it has to specific timeline. As a provider, safety is more important than confidentiality. So the board exam might ask you with that. Do you have, if your patient tells you like, I want to, please keep this as a secret, but I want to kill someone tomorrow by stabbing them, and it's my supervisor. Although the patient tells you that, oh, it's confidential, you have to report and take steps to make sure that the potential victim is informed, okay? Why the others are wrong? Again, confidentiality has limits. So during intakes, you have to tell the patients, you know, this information that you are telling me is confidential. But in the event that I feel like there will be harm, potential harm, or safety is at risk, you know, I have to inform that person. Okay. Explore childhood trauma, not really a priority. Follow up next week. This is extremely dangerous. Please don't do that. Okay. You have the duty to warn. Okay. Memory trick. SIP. So if it's serious, identifiable, and planned, you have to inform the person that they are in danger. Okay. Again, remember SIP, SIP, serious, identifiable, and planned. Why? Because it has a specific victim, it has a plan, it has a specific timeline. Okay. And then let's look at our mnemonics. All right. So do acts, do act. So do act. All right. Danger to self, others in danger, abuse or neglect, court orders, as is safety emergencies. So things think do acts when confidentiality can be overridden. These are cases wherein, you know, you can override confidentiality. So if there is danger to self, dangers to others, abuse or neglect, court orders, or safety emergencies. Regarding abuse or neglect, we are mandatory reporters, okay? Every state may have a different timelines as to when the paperwork should be done. However, it has to be reported right away. Remember from yesterday, do you have for patients who are suspected abuse or sexual assault, do you have to do a physical assessment? Do you have to verify the information? No. If there is suspicion, you have to report it, okay? So, quick recognition, especially for your duty to warn. Confidentiality is important, but not absolute. There are some situations that the disclosure is needed to protect the public safety and to protect that person. Think imminent harm, legal mandates and emergencies. So every time you see a patient, what are the questions? What are the questions that you have to ask? Do you have any thoughts of harming yourself? Do you have any thoughts of harming other people? Every time you see these patients, you have to ask your safety questions. Okay? So, board exam pearls, okay? Classic board clue. When the board exams question includes client presents an imminent risk of harm, absolute abuse, neglect, reporting duty is triggered, okay? Court order or urgent safety issue is present. Question asked about the priority or legal ethical actions, like what's your major responsibility? So you have to report. All right. Good job, everyone. Next question. Okay, second to the last question. Question number 9. A client with borderline personality disorder has chronic self-harm, emotional dysregulation, unstable relationships, and black and white thinking. Which therapy fits best? Again, a client with borderline personality disorder has chronic self harm, emotional dysregulation, unstable relationships, and black and white thinking. Which therapy fits best? A is DBT, B, psychoanalysis, C, ERP, D, light therapy. You guys are fast. Everyone knows this. Everyone should know this. This is heavily tested in the board exam. Answer is letter A, DBT. So it targets emotional regulation, distress tolerance, interpersonal effectiveness, and mindfulness. So for memory trick, okay, for DBT. So DBT, don't be triggered, okay? So it treats self-harm, emotional dysregulation, and it is a number 1 management for bipolar, not bipolar, for borderline personality disorder. Okay, why the others are wrong? Psychoanalysis, not the first line. ERP is for OCD or obsessive compulsive disorders. Light therapy, it is used for seasonal affective disorder. So you have to memorize this, okay? Mnemonic to remember. DBT is balance. B stands for build skills. A for accept emotions. L, learn mindfulness. A, act effectively. N, navigate relationships. C, cope with distress. And E, end self-harm. So board pearls. DBT is the gold standard therapy for borderline personality disorder and chronic self-harm. It targets emotional dysregulation, impulsivity, and unstable relationships. So it focuses on skills on 4 major modules: mindfulness, distress tolerance, how they should be able to handle their emotions, emotion risk regulation, interpersonal effectiveness. So it is a long-term commitment. It's not just like a 1 week treatment. It is a long-term commitment therapy and skills practice outside of sessions. They're very important. Sometimes they give patients with assignments. Okay. So the aim is to build a life worth living. So quick guide for your therapy and your for therapies. It's one of the important things that you have to remember for the board exam, okay? DPT is for borderline personality disorder. Even if the question never mentions borderline personality, but if you see the word self-harm, the question would be, the patient is telling you that they like to harm themselves. What would be the best therapy for them to have? It should be, the answer would be DBT. ERP is best for obsessive compulsive disorder. MI, what is MI? Anybody? MI. It's heavily tested on the board exam. Motivational interviewing. It's best for substance use ambivalence. If the patient tells you, like, I'm not sure if I want to get treatment. So, what will be the therapy that you're going to incorporate is motivational interviewing. Yes, good job. Good job, Crystal. And CBT is best for distorted thoughts, depression, and anxiety. So, CBT is your cognitive behavioral therapy. Good job, everyone. All right, let's go to our last question because we have 5 minutes left. Wow. So, an older adult with psychosis refuses medication but understands the diagnosis, risks, benefits, alternatives, and consequences. What is your best action? Again, an older adult with psychosis refuses medication but understands the diagnosis, risks, benefits, alternatives, and consequences. What is your best action? A. Force medication. Do we do that? B. Respect refusal if capacity is present. C. Ask family to consent instead. D. Discharge immediately. Okay. You have some answers. John said B. Maikia said B. Mopisola said B. And the answer is, everyone's right, it's letter B. You have to respect, especially if the patient has the capacity to make decisions on their own. Okay? Why others are wrong? Do we force medications? No. Why? Because of the concept of autonomy. Patients have the right to refuse as long as they have to, they are on the right mindset, they have on the right mental capacity to make decisions on their own. So, capacity requires ability to remember your UARC. How would you check for capacity? They are able to understand, they are able to appreciate how the consequences apply personally. R for reason, compare options and explain the rationale. And C, communicate, state a clear, consistent choice. That's why in your charting, if patients are refusing, you have to make sure that the patient has been informed of the risks and benefits or the risk of refusal of this medication. And you have to add what they verbalized understanding. Okay. And so if we go down on all the choices, we don't force medication. Only if the patient lacks capacity, family consents, or what else? If there is an advance directive or there is like a durable power of attorney. So if the patient doesn't have the capacity to make decisions on their own, ask, is there a durable power of attorney? Is there an advance directive? Discharge immediately? No, not appropriate. Just because a patient is refusing medication, do you have to discharge them? No, okay? All right, for board pearls, so diagnosis does not equal to incapacity. So psychosis alone does not remove decision-making capacity. So this can be tricky on the board exam. Decision specific. So capacity is assessed. You have to make sure that the patient has the capacity to make decisions. For this medication decision, okay, only not globally. Honor informed refusal, okay? If the capacity is intact, respect refusal, even if you disagree. Again, like I said, document and reassess. Record the capacity assessment, reassess if risk or status changes. So do not assume that the age or the presence of psychosis is equal to the lack of capacity. Okay, so again, if you are enjoying our review sessions, and then if you want to have something in handy that would really help in reviewing for the boards, or even if you are a new grad and you're starting your practice, we have the PMHNP Mastery Psychopharmacology. So right now you can get 10% discount. So use the coupon code PASS10. So It has high yield content. It has safety side effects, what monitoring, what labs you have to monitor, what are your normal values, prescribing pearls, these like smart choices, like clinical judgment, especially if there's like polypharmacy, prioritizing what medications, board style applications, so case-based questions, and then high yield facts. This is very, very helpful that could guide you and help you on your practice. Okay. Oh, okay, Janet, is there a way to receive this recording? Let me ask if there is a recording, but of course, on June 27, join us. Pacific time, 8 a.m. to 2 p.m. We're gonna do a last minute prep. So join us and we're gonna help you and guide you. We're gonna do something similar. We're gonna break down, but we're all gonna discuss. Um, Yes, we're going to discuss everything, especially we're going to put importance on what we think might come out of the board exam. Some of these questions may have mirrored the actual board exam questions. And stay tuned for our next live session. We'll be announcing it. Go ahead and follow us on social media. Thank you so much, Latonia. Thank you so much for supporting. And I tell you, it's really very, very, very helpful. It kind of like breaks down the important things that you have to know when you are practicing, and also if you are preparing for the board exam. So to enroll, yes. So that one, so these sessions that we're doing the live is free, but the last minute prep is going to be paid. So you have to scan the QR code. It's flashed on the screen right now. So for the book, someone will put on the chat. Okay, and we're running out of time. Thank you so much. So if you go on our social media, the link will be there. If you subscribe and follow us on social media, you will get the notification that we're going to do another live class. Congratulations in advance, and thank you so much for joining us, and hope to see you soon again on our next live session, and hope to see you all on our last minute prep. Bye.